A very good evening to one and all, and it gives me a pleasure to welcome you all to today's Flavor of the Month CME Series. And before I go on, this is Dr. Karpagam. I am a senior consultant at the Periyar Nagar Agarwals, and it's been close to 12 years of experience with Agarwals, and also the Dean of the Optometry College at Agarwals Institute. So it brings back all those old memories when I served as the education chair. And to see today that Agarwal's clinical board or the education committee YouTube channel has close to 2,900 YouTube viewers. And thank you for being this one part of this wonderful journey at Agarwal's. So going on to introduce the speaker for today, we have with us Dr. Dhivya Ashok Kumar, who is a senior consultant at the Oculoplasty and Uvea Services at the Center of Excellence, Chennai. She has an MBBS and MD from AIMS, FICO, FAICO, with training from AIMS Delhi. She has 18 plus years of teaching experience, and she's been the faculty for the National Board on Lecturer at the Muthuswami Virtual University. She's got close to 130 PubMed index publications and 40 plus book chapters. She's also the editor of the OCT textbook. She has over 5,700 citations and a H index of 33. She's got multiple national and international awards to her credit at the ACRS, AIOS, IIR site for innovation, teaching, and research. She's also the reviewer for top global journals, including IJO, ACTA, JCRS. Her core interest areas being ocular oncology, uveitis, surgical techniques, and device innovation. She's also the organizer for various national CME programs, including our own postgraduate teaching, Kalpraviksha, which happen once a year. So today's session focuses on VKH, which is a complex multi-system condition that often challenges even the seasoned clinicians. So with its wide spectrum of ocular and systemic manifestations, VKH demands early recognition and a multidisciplinary approach to management. So we are privileged to have an expert with us who will walk us through the clinical nuances, diagnostic dilemmas, and evolving strategies in managing VKH. So I encourage everyone to stay engaged, ask questions, and make most of this interactive session. So let's just dive right in. Over to you, Dr. Divya ma'am.
Good evening, everyone. I thank the clinical board for giving me the opportunity. Thank you, Karpagam, for the nice introduction. Today's topic is on challenges and spectrum of VKH management. I took this topic because most commonly we see these patients in our OPD, and we confuse with many conditions, and we have faced challenges during treatment in these patients. The basic about the embryology in such eyes is the germ layer, which is the neural crest, which has got the preponderance of producing few cells which are common in the system. Like you have the peripheral nervous system, which produces the neurons and neuroglial cells, pigmentary cells, which are present in various organs like skin, ear, and eye, and neurons. Connective tissue like corneal endothelium, stroma, and iris. So this neuroectodermal is a specialized tissue that orchestrates the intricate development of these structures like brain, spinal cord, and nervous system. And it's associated with the development of the corneal and iris tissue. In VKS, there's a multisystem disorder involving the melanocyte-containing organs such as uvea, ear, and meninges, which has got the common ectodermal origin. The history of VK is widely spread as early as 12th century. It was the first physician, Muhammad al-Ghafiq, who had described the disease with poliosis, neuralgia, and hearing changes, followed by Alfred Oak, who identified the bilateral chronic iridocyclitis with poliosis, vitiligo, and dyschezia in 1906. And then later, Koyanagi identified and noted similar series, first in German, then later in English. And he had published a few series till 1926. At the same time, Jonsvik Harada published a few cases of posterior choroiditis with the symptoms of neurological and CSF changes. So in 1932, Professor Jean Bebel of Geneva coined all the terms together and making it as the Vox-Koyanagi syndrome. Coming to the etiopathogenesis, exact etiology is unknown in this condition, but there have been some theories mentioned. Like you can have a T-cell mediated immunity against the melanocytes following recovery from an inciting viral infection. Cytomegalovirus, Epstein-Barr virus have been implicated in the disease process, but there is no definitive link identified. Basically, it is a non-necrotizing granulomatous inflammation in the eye, inner ear, skin, and the air due to the loss of tolerance of melanocytes. In the epidemiology, if you see, it usually affects the pigmented individuals. It has been noted to have high preponderance in Spanish and Japanese people. And this is also one of the most common cause of uveitis in India. You see, in Japan, it's around 6 to 9%. However, in United States, it is around 1 to 4% only. Gender predilection has been noted. Yes, in females, it has been shown little more predilection, especially in patients with subretinal fibrosis and CNVM. The mean presentation age is the middle age from 30s to 40s. It has been reported in children also, like less than 16 years. Diagnostic criteria varies, and there have been two criteria, GEM, but the recent criteria which we will be discussing is on the differentiation into complete, incomplete, and probable. It is the most commonly used one. And there are three conditions which are required dominantly to diagnose VKH. First is there should not be any history of ocular trauma or surgery preceding the initial onset of uveitis, and there should not be any clinical or laboratory evidence suggestive of other ocular diseases. Suppose a patient, if he has a pan-uveitis and he fits into all criteria. So bilateral ocular involvement is a third criteria. So if a patient fits into all the three criteria, especially the first two, which is mandatory, then you go into the third ocular involvement. This ocular involvement can stage or in the late stage. Suppose a patient, if you see in the acute, seeing the early manifestation. If you see the patient in late stage, or if he comes after getting treatment somewhere, or he missed the early treatment, you will be seeing in the late stage. The early manifestation could be a choroiditis with or without anterior uveitis, vitreous inflammation, optic disc hyperemia, focal areas of subretinal fluid, and bullous serous retinal detachment. Late manifestations could be ocular depigmentation, sunset glow fundus, and Sugira signs and depigmented scars. These patients can be said as a complete other system involvement like the neurological, auditory, and skin. Neurological can be presenting as cranial nerve palsies, meningismal signs, tinnitus, and CSF rheocytosis. Skin changes could be alopecia, poliosis, and vitiligo. So the complete VKH is when you have all the 5 criteria filled up. Incomplete is 1 to 3 is filled up, but either 4 and 5 must be present. Probable VKH or an isolated ocular disease is a criteria where 1 to 3 must be present for diagnosis. In genetics, if you see, there is an HLA coordination noted in these patients. HLA B1 associated, and the loci, multiple loci have been described. T-cell mediated autoimmune dysregulation targeting tyrosinase family proteins and GP100 is found in VKH disease. Predominantly affects the pigmented races. Clinical presentation usually starts with a prodromal stage with mild fever, myalgia, sometimes can have tinnitus also, cranial nerve palsies. In India, if you see, majority of these patients have more of ocular symptoms rather than the extraocular signs. Bilateral granulomatous panuveitis is the hallmark of this condition, where you can see multiple copies and Brusaka nodules with acute inflammation in the anterior chamber, posterior synechiae formation, mutton fat capes. Shallowing of anterior chamber in the initial stages might be due to the edema of the ciliary process. There could be different IOP presentation. Either it could be low or high when they have choroidal effusion with with low pressures, or they can have increased angle, secondary angle closure causing increased intraocular pressure. In a series by Foster et al., they have noticed 16 out of 42 VKH presentations required medical or surgical management of glaucoma, going in for pupillary block. Optic disc edema with vitreous inflammation can occur as the disease evolves. It could be dilated tortuous veins and disc edema. And non-rhegmatogenous exudative RD is a classic diagnostic feature of VKH. In the later stages, you can see multiple Dallen-Fuchs nodules with their depigmented spots seen in the peripheral retina. It is characterized by the granuloma formation between the RPE and the Bruch's membrane. There is an index called sunset glow index. As you can see here at presentation, as the time goes on, you can see the change of the glow of the retina. So this is called the sunset glow fundus, which happens as the time progresses from presentation to months later. In the convalescent phase, so we have seen the prodromal, then we have seen the uveitic phase. Then the convalescent phase, there will be integumentary features like alopecia, vitiligo, or poliosis. Sunset glow fundus, we have seen Sugira sign is what you see, the perilimbal depigmentation, as you can see in this patient in the convalescent phase. In chronic recurrent phase, there could be mild smoldering anti-uveitis with exacerbation, more common than the posterior. Sunset glow fundus with bumpy optic disc PPA. Then many of you might have seen in your OPD that bumpy disc is seen in patients who are pseudophakic actually. And sometimes you will be asking them what did they have any floaters or anything. They can have a resolution of this VKH which was diagnosed earlier. But if you see such bumpy disc with the peripapillary with depigmentation, you should always ask for the history and make a note of it. Complications on long term can lead to subretinal fibrosis, glaucoma, cataract, and choroidal neovascularization. So this is a patient with a bumpy disc with Dallen-Fuchs spots here, and which is typical of the VKH. So coming to the overall clinical pictures, you can see in acute stage is more of a granulomatous inflammation, where you see the inflammation in vitreous and excretive disc edema, hyperemia. In the convalescence, it is a light of non-granulomatous shift over, which is happening with the symptoms getting lower down, the depigmentation starting, Dallen-Fuchs nodal appearing. Again, in chronic recurrent, again there is a granulomatous. So it is a shift of fluctuation up and down, which happens in the VKH patients. And initially in the acute stage, in the histopathologically, you will see the involvement of choriocapillaries. It will not be there in the initial stage, but later involvement can be present. What are the common differentials you can look into? So the close differentials would be the sympathetic ophthalmia, sarcoidosis, and posterior syphilis, especially in the middle-age group where, and as you all know, the symptoms are more or less same in sympathetic ophthalmia VKH, but you will have a preceding trauma in the sympathetic ophthalmia patients. And the sarcoidosis and posterior syphilis, the lab investigations will be done, history will be little different from them. These patients will also have to rule out other neoplastic and paraneoplastic conditions and inflammatory autoimmune conditions and infections like tuberculosis. That's why lab investigations are more important. And before we jump into lab, we usually do some baseline workup for these patients, like you do an optical coherence tomography, in which we will be looking for the RPE folds and subretinal membranous exudates, hyperreflective spots, fibrin. And as you can see here, there is undulating RPE level. There is subretinal fluid here, elevation of the fovea. And you can also see some septations and fibrin deposition here. These are all typical of the VKH. There is a bacillary layer detachment commonly seen in these patients where there is a split at the level of the photoreceptor in the inner segment myoid, creating a distinctive intraretinal cavity, but it can also be seen in other conditions like neovascularization or drug toxicity, etc. The close differential in OCT will be the CCSR or central serous retinopathy, where you have to look for the clear fluid, where you will not see any septae, there will not be any membranes there. There is no fibrinoid description in the subretinal space. So that is the central serous retinopathy as compared to the, you can see here in the picture, the upper one is the VKH and the lower one is the clear fluid, which is seen in the serous retinopathy. And if it heals, then you can see that irregular changes in the photoreceptor. So the common differentiation which you can look into in the CSR and VKH is the disc hyperemia and disc leakage on FA will be present in VKH, will be absent in this central serous choroidopathy. And the RPE change will be present in the CSR. Septae and folds are absent in the CSR. The other sign which can look, you can see in the evolving phase of VKH is the sawtooth appearance. As you can see in the outer plexiform layer where the arrows show is a sawtooth appearance of the inner outer retinal layers where there is a healing happening, and this is represented as the finger dot sign. As you can see, fingerprint sign, like you have the fingers printed here, which is seen in the end phase OCT. This is also a feature when you see in the evolving VKH. Coming to the fundus fluorescent angiography, which is can be done in patients in the acute phase when they present to you. If there are no other comorbidity or renal pathology, you can go for FFA. You can see pinpoint leaks. These are the pinpoint leaks, and you can see some serious detachments here where there is pooling of fluid, starry sky appearance, which is a pathognomonic of VKH. So this is another patient where you can see the bilateral involvement with this hyperemia, disc leakage, and there is starry sky appearance and SRF pooling. You can see the light appearance of the fluid. As the time goes on, you can see the more pooling happening. ICG is another investigation which is useful, but more centers will not have ICG. In the acute phase, you can see focal areas of delayed choroidal perfusion, capillary hypersynosis, late pinpoint leakage, and pooling in the area of serous retinal detachment. And this is the choroidal granulomas ICG has more predilection for the choroidal perfusion, you will be able to see the choroidal granulomas better with ICG. And you can also see the choroidal folds here, or the lines of the choroidal folds. When there is extensive fluid or a serous fluid dissipating with the serous detachment, it is the blocked senescence what you are seeing. Other investigation which can be done in few centers could be the autofluorescence. Autofluorescence basically depends upon the RP layer when it is very active, and you can see the autofluorescence which is there. But when the difficulty is there, the RP function is affected or there is absent, then you can see the difference as changes in the autofluorescence. It is an acute phase, and this patient is in the chronic phase where you can see there is of this, there is proliferation of RP. So RP is not in a single place, it's all dispersed everywhere. So you see the dispersed or disturbed region in a chronic or convalescent phase. And this is another investigation, which is ultrasound, which is commonly being done because it is easy for everyone to go and do it. So when you have a non-dilating pupil or a pediatric case where you cannot directly go for an FFA, or a patient is not affordable for an OCT, this is the investigation of choice modality which you can come into, where you see here the vitreous echoes, and there is thickening of the posterior layer, that is the retinochoroidal thickening will be there with SRF. So then when you see this choroidal thickening and all, you should rule out another condition, which is posterior scleritis, which will also mimic like a VKH. As you can see, there is a fluid accumulation on the fovea, and there is some ILM striae on this photograph. And if you see the autofluorescence, you can also see this ILM striae and fluid, that is the absence of the mild, the texture of the retina. Normally 6-6, and he noted sudden change in the hyperopic shift +4 and +1 either of the eye. So here you can see on OCT there is a bump below the choroid. So the retina is normal, fovea is normal, but something from below is shifting it. So there is a push from below. So this is actually the scleritis. If you see the ultrasound actually in this patient, there is a scleral inflammation and early T sign and pushing the choroid above. And this patient was diagnosed as scleritis and put on the appropriate treatment. So these are the baseline investigation you can routinely do in your cabin. Whichever is available to you, you can use whatever for the diagnosis of a VKH. And bed evaluation you have to do before going in for treatment. That is the complete hemogram, ESR, CRP, and MATO is required because some undiagnosed tuberculosis can sensitivity obviously, and sugar levels are required because these steroids come into play for treatment. Renal function for FFA fitness, on long term they might be on immunomodulators, so we need to get the renal parameters. Comorbidity should be evaluated, so LFT is required. Serum AC torch infection quantiferon can be case specific, that is up to the physician whether he wants to do it or not, he or she. So this is about grossly about the VKH. Let us go to some challenge see in my OPD. So this is a story of a 54 years old female patient who was a homemaker examined by a general ophthalmologist in 2018. And she was a known diabetic and hypertensive, 10 years on medication. She had come to their OPD and they have noticed a BCV of 612 and right eye 624, and IOP was normal, and they have noted a foveal reflex was dull. She was asked to do an OCT at that time, but the patient did not follow up their prescription and she left. She comes back to a neurologist in November 2020 with a persistent headache. She goes to a neurophysician where they advised for an MRI, but the MRI was normal. She was put on oral Diamox for a few days and she was not able to tolerate the Diamox. She was referred to an ophthalmologist. So she comes to us, we examine her to have a right eye vision of 636 and left eye 660. That means the vision has already dropped from the day when she's even she was absolutely normal as per the history, she says, and the cells flare was noted. IOP was normal. On examination, this was the picture of this patient with bilateral disc edema, tortuous veins, and you can see these multiple fluid accumulation, ILM folds. And this is the FFA picture. Immediately we went in and we see macular edema there and the fluid accumulation. There is SRF also. So this is the undulating RPE as we have shown before. The same thing was there and increased foveal thickness, and there is increased choroidal thickness. So this patient was diagnosed because she didn't have any other integumentary findings. So she was a probable ocular VKH patient, and she was put on medications, and all the investigations like manto quantiferon, everything was normal. She was on IV pulse steroids followed by oral steroids. 2 weekly she was reviewed. Her vision improved up to 6/24 near vision to modulated therapy methotrexate. And even after methotrexate, we noted our vision did not improve. So we had to go for an OCT angio. So this is about 2 months when she had come for follow-up. Vision was still not improving. Then we noted she had a spurt of blood vessels in the fovea. As you can see here, then we did the OCT angio patient. Because the renal parameter GFR was affected, we could not do an FFA again. So she went in for there is new vessels spurting out in the macular region. This is the other eye, so she had a bilateral neovascularization. So with the retina consultation, we had to give her anti-VEGF, and her vision improved to 1 line more, and the near vision also improved. And so she is 624 at that time. Because she was affected, we had to give her a milder or planned for an oral methotrexate with folic acid, and she was on that. Then came the COVID era, COVID vaccine, and she got into COVID also. So they had to stop her steroids and methotrexate. So this is where the CNVM scar formation started, and she went in for urinary tract infection. When that another reason why we had to stop her steroids, we cannot continue her steroids. Her HbA1c during that time to 9.5. So during that time, she was off these immunosuppression, and she came back after some time on IMT. In August, again, the problem I had to face, she developed a foot ulcer where she has to go for a diabetic ulcer treatment, and the graft was placed for that. So we had to stop her steroids again at the time. So after graft recovery, she came back. This is the time when she came back in October, few years the next year. August year in October when she came, she had a recurrence of granulomatous inflammation. As you can see, the copious nodules again coming here. So IMT. So she is still on IMT now. Now this is the single patient in which I'm seeing that the entire course, like for every patient, it will be like this. For a VKH patient, as you evaluate, there will be lots of ups and downs, fluctuations happening. And because these conditions can be affected by the predispositions, how they are compliant with the treatment, how they are tolerable for the treatment, what are the comorbidity. And finally, she is landed up on at least an ambulatory vision right now. And this is her vision 624, 660 with all the macular scarring. And she is maintained with the immunomodulators. No edema, but she has a scar in the macula. So the point here to discuss is this patient was initially seen, and she has gone, and she later comes back with the acute inflammation. This patient could have been seen in the later phase. That means the hyperacute phase where you will see the pinpoint leaks was not seen in this. So the patient with this pinpoint links have shown to have better resolution of the disease when you start on the early treatment. Maybe this is a disease when you pick up the patient in the hyperacute stage. An initiation of the first line treatment of immunomodulator, especially in patients like this, when you have a comorbidity, when the compliance is poor, in that case, the IMT can be combined in the initial stage to prevent sequelae. Now, another evolutionary thing we should look of is the retinal oximetry will be less in such patients because retinal oxygen metabolism is altered in uveitis, especially in VKH. And there is also association of HLA DR4 in such patients. So there is a pathogenesis also. They say there is a T cell mediated autoimmunity and viral trigger could be the common factor, which could be a correlating factor for these two conditions. So they have also reported similar studies of this complication happening in a diabetes and a VKH combination. So steroids and VKH is the thing. Most of the patients will be starting on first line treatment. Yes, it is IVMP, which we give pulse therapy for 3 doses after clearing for the physician, and followed by the high dose oral steroid, or you can directly start on high dose oral steroids. 5 PMP is not affordable, or it's not available in the center where they cannot give an IV dose in the initial stage. 3 predictive factors which will tell you about the poor visual outcome is one is the age, or older age at presentation, or chron. If you see the patient, like as I said, you miss the hyperacute stage and you pick up them in the late stages, or patient has developed with CNVM, this will affect you. Usually happens the first 3 months, And if you see, this is almost 43% recurrence noted in one study after tapering, rapid tapering of steroids. That's why we prefer to slow tapering of steroids. Early aggressive use of systemic corticosteroids in patients with VKH and tapering with over a dosage of 6 months would be the better option. Antimetabolites, T-cell inactivators, calcineurin inhibitors, and purine analogs are the common immunomodulators used in VKH. There have been a lot of studies and methotrexate or azathioprine, which one works for you and which one is comfortable or tolerable for the patient. And it has to be sorted out with the person, physician, and the patient, and especially the corticosteroid sparing effect has to be decided. And usually we'll go for azathioprine and methotrexate. And the studies have shown azathioprine 86% given in the initial acute phase, it has got a good sparing effect, and 90% MMF have also been started with systemic steroids. So first line therapy, antimetabolite, this is the fast trial which has been included with the randomization of 216 patients in a non-infectious uveitis, in which they have identified, including patients for methotrexate or mycophenolate. And they have noted use of mycophenolate was not superior to methotrexate in terms of controlling. So see, these are all studies which will come out on the dependence. But again, physician has to decide which one is comfortable for the patient, taking into account of the comorbidity and tolerability of the patient. There's another study in China in which they reported starting only on IMT and as associated with the other group, which is on the corticosteroid group. They also showed that this means the systemic glucocorticoid free. That group was very safe and well tolerated. In children, like you said, is less than 16 years, they can, if they develop the choice of immunomodulator usually is the methotrexate. There was one condition like VKH, which we recently saw in this post-COVID duration, that time where we saw a lot of patients having the first episode of their VKH during that period, especially after vaccination. So we reported it as a like syndrome. As you can see, this young patient who had a clinical presentation like his the septations and fibrinoid changes, and as you can see in the FFA, there is a pinpoint leaks, vision drops. So these are a series which reported. These all patients had a vaccine and within 3 months duration, and they have developed the features like you have these posterior segment exudative bodies, choroidal changes with the vaccine after. So maybe that vaccine might have triggered the inflammation. So there is a mechanism in which vaccine-associated uveitis include direct infection of the uveitis, and molecular mimicry theory can also be predisposition for the related inflammation. All these patients got cured, and with steroids they all cured. There was no recurrence actually. Maybe that one single trigger might have caused, and this also you have to think into when you see a patient for the first episode. Was there any vaccine given for any other condition? So this is again an interesting case in which the patient came with an angle closure attack, increased IOP. As you can see, fibrin on the lens, closed angles in both eyes. Gonioscopy shows closed angles, but she on USG you can see, and obviously we cannot dilate her. That's why we did a USG for her. You can see there is a fluid here, choroidal thickening, effusion happening. That's why angles are closed because of the ciliary edema. So this slowly on steroids, she recovered. AC became the depth of the AC became normal, and PI, you can see that opening here, and the AC became normal. In these patients, if you see, there is iris depigmentation. As you see in the RPE depigmentation, the iris also goes in for depigmentation. And especially in the pigmented race, in our Indian population, this is one of the classic signs you will see all the vacation convalescent phase, they will have this pigment releasing slowly from the iris. And you should note, so whenever you see this melanin getting dispersed, you should always, can there be a VKH compound? This patient, this is the post-treatment USG, which is absolutely normal. And this is the fundus also normal. After that means you have to pick up the patient in the early stage. This is the patient picked up in early stage. She also went in for cataract surgery, 6/6 vision, IOP stable. Of course, she has the pigmentary changes, which is a sign that she had a VKH1 episode. This is another patient. We have a few cases of one-eyed patient. This patient actually we reported. This patient came with acute onset pain, redness in one eye. Other eye is like this. From childhood, she is like, well, obviously, we had to go in for a B scan. This is the B scan. You can see the thickening here. There is a SRF, there is a subretinal fluid. She was given IVMP and on oral steroids followed by that. Then association, what we noted in this patient was there was an agenesis of the distal part of the corpus callosum and pericallosal lipoma, and there was mild reduction in the optic nerve. Also, this was just an association, nothing to do with the VKH. Coming to this patient, this is another patient where acute presentation, young patient with SRF and disc edema. You can see that the pinpoint leaks. You see this time frame of this in March 2021 was seen, and this is another eye of the same patient, and this is the septate changes and the SRF. This is the treatment. After treatment, she gets a better improvement. SRF reduces, but 4 months later, she comes back with recurrence. That means in between, the patient did not follow up and she was off steroids and she was not on immunomodulator. And that's why she has been, there is a fast 4 months later. So this again, the patient was now, she understood that the fluctuation can happen. She comes every month for changes that happened to her over the time period, almost 2 years, where you can see the proliferation, RP migrating, slowly dispersing, and finally sets into the Dallen-Fluke's nodules. You can see the mid-periphery in the later stages, 2 years later. She also developed cataract. She went in for cataract and she gained 9, and still she is on immunomodulator, methotrexate with low dose steroids. This is yet another patient of one-night patient where sedation, undulating RP here, non-dilating pupil, and you can see in the SRF here, there's an exudative retinal detachment, thick and poroid. And this patient was absolutely, she doesn't want any oral treatment because she feels the face becomes puffy and she cannot take, and she's from a far off village. So these complications or challenges we will be facing in patients where we treat and absolutely that is only one eye for the patient. The problem was already when she came, she went in for a secondary angle closure and she had a cataract also. This is the cell count was low. So this situation, she had to go in a high risk consent. We had to go under steroid cover. Obviously, the inflammation after settling with IVMP and oral steroid, she went in for a phaco and improved her vision at least 624. But again, PCO very because come for follow up or a non-complaint with oral steroids because she's very much concerned about her facial puffiness, and she came in with the PCO very soon. But again, I have to take her under steroid cover, put her again on oral steroids, and immunomodulator has to be started. And she went in for a YAG up. This is the YAG, post-YAG status, where you can see the small hole here. Now she's having ambulatory vision, and this is the fundus picture. And she's almost 1 year now, and you can see the Dallen-Fluke spots, and retina is attached without any SRF. And this is yet another one-eyed patient. This is the only seeing eye of the patient in which we did a phacoemulsification, and she is able to get an ambulatory vision. This is the fundus photo of the patient where you can see the depigmented fundus. This is another interesting case in which the younger sister had come for me for the treatment in which VKH was diagnosed, 20 years old female with one eye phthisis and other eye. This was the initial presentation, FFA cases. We gave her steroids oral treatment, and after treatment, convalescent phase, and this is the Dallen-Fluke spot we saw. Actually, she was coming for follow-up and was on immunotherapy, and she was absolutely in the follow-up. She got her elder sister, in which I noticed she was having vitiligo. So I noticed that this patient had a VKH presentation, and there could be a predilection the family members can have an other autoimmune, but the mother was absolutely normal, didn't have any other autoimmune condition. So siblings can also, you can check into their. In pediatric VKH, pediatrics it is a little difficult because giving the steroid therapy, getting a overall control, clinical based and study was done. And the incidence was 1 case per year, and systemic steroids followed by IMT is the usual treatment. Visual loss occurs most typically as a result of cataract, glaucoma, or RP. Subretinal, the complications are usually like treatable in the initial phase, like you have a glaucoma or a cataract. But the very difficult complications could be a subretinal fibrosis or choroidal neovascular membrane. 33% of them can develop an ocular hypertension. Glaucoma develops could be steroid response, angle closure, or a pupillary block. The challenges usually we face is, as we told, one is the recurrence. Despite treatment, many of them, they can have recurrence. That's why they should have a continuous ongoing monitoring. And complications like long-term corticosteroids can lead to complications of cataract. Immunosuppression therapy can be challenging due to the side effects. Individualized treatment is more important, and like the treatment approaches should be individualized based on patient-specific needs approach using the ophthalmologist, neurologist, and other specialists is required. And corticosteroids have an established role in treating VKS, but data show increased recurrence and complications when used as a monotherapy. And if it is used IMT, it is very much useful. So take home message here is the catching the therapeutic window of opportunity is a very early case of acute uveitis associated with VKS disease prevents progression to chronic recurrent evolution and development of complications. Patients with OCT angio even as early as 2 months post-treatment to prevent CN or to detect actually the CNV. And diabetic status, comorbidity, nephropathy, neuropathy all should be addressed. Vaccination and viral reactivation can also be a limiting complication, hence prognosis should be always discussed with the patient. So these are all references. Thank you.
Thank you, Divya ma'am, for this elaborate presentation. I think you really clearly walked us through the various investigation modalities which can be used, walked us through how to go about treating a patient. And we still have a lot of questions with respect to how to go about treating patients with immunosuppressives. So we'll start with the questions right away. And so the first question is, can you please elaborate on what is meant by a bumpy opti disc?
Chair, it is not elevated, but it will appear bumpy. It is like an illusion. So I'll show you that image again.
I've had seen cases where long-standing VKH, they tend to
Yeah,
develop.
long standing only. Yeah,
Yeah,
long
I have
standing VKH.
going on to
So this
develop
is
peripapillary CNVMs. So that could probably explain one of the reasons. And as you are tracing back, I think one more question with respect to the presentation is multiple serous detachments commonly seen in VKH?
multiple.
Serous detachments.
Yes, yes. Multiple serous detachments are seen because it is happening like in multiple places, choroid. So you will have the small choroidal granulomas. There is an RPE function which is being affected. So there is a perfusion difference. That is why you get the together, and you can see the extensive exudative retinal detachment also.
Exactly. And this is one of the reasons why it's confused with a multifocal CSR. If it's going to be just a central CSR, it's not usually confused with VKH. But when you have a multifocal CSR, it's often confused with VKH. And I think it's quite evident that you have to differentiate because the line of treatment is just the opposite for both of the cases. So there are a lot of queries with respect to the therapy. So the first question is some inputs on how to start immunotherapy. What are the do's and don'ts which we have to mind? And when do we have to refer uveitis patients to a specialist? So we'll take it one by one. Any inputs on starting immunotherapy? I think Dr. Divya ma'am has already clearly, elaborated what are the immunosuppressives which would work. If you could just summarize that, madam, it will be great.
Yeah. So immunosuppressants can be like anti-metabolite, which has got less complications than methotrexate, and it will be the drug of choice for initial patients who are like having comorbidity. Suppose an elderly patient, you can start initial phase. Usually start in the lower dose and see. And before that, you have to do a baseline workup for these patients. Like you do a complete hemogram, LFT, and RFT should be done. And anything which can predispose, like if they have never start on any immunosuppressants. So that has to be treated first. Then only this immunosuppressants can be. And you have to get a physician clearance if they have a comorbidity. This patient requires an immunosuppressant. If a patient is a well-built, there is no comorbidity, you can start on methotrexate. That is one. The other line of treatment is the azathioprine, which is a purine analog. And this patient complications are usually nausea, vomit, and some changes of hepatotoxicity and renal toxicity also noted. So anyway, you are going to do the blood profile, and you will be starting them on 50 milligram or 100 milligram. Basically, I would start the patient always on the lower dose. I am a conservative physician, so I will start 50 and see how the patient is able to cope up. They're tolerated, and this is on the inflammation, how it is settling down. So depending upon that, you can just monitor it over the time, active or inactive, or it is able to reduce. At least 3 months you have to try that, unless and until there are any complications. Once you start on either methotrexate or azathioprine, measure their CBC and LFT every 6 weeks. and see if there is any side effects because of the oral medication. Mycophenolate usually rheumatologists give for SLE and rheumatoid other collagen vascular diseases. Nowadays, they are starting in VKH also. If you want to start a mycophenolate, you can get a rheumatologist consultation and start on that. So basically, if they have a additional comorbidity, that is where we get the physician opinion. For young and well-built patient, you can start on methotrexate. Only thing is monitoring is more important.
Ma'am, I would like to add on that generally when we see a VKH patient, we tend to start them on dual therapy. That is, an immunosuppressive is always combined with a steroid. So because the posterior polus involvement, you want to intervene early. And if you see it is quite aggressive, I would suggest that we can go on with IVMP, 3 doses, 1 gram in 500 ml normal saline for 3 doses, 3 days consecutively, and then put them on oral steroids at the dosage of 1 milligram per kg body weight. Most probably it will be 60 milligram. And you can taper it every weekly. You can taper it by 10 milligram every weekly till it reaches a dose of 30. And then probably take down every 5 milligram. So all this should be done in conjunction with an immunosuppressive. The thing about immunosuppressives is it may take close to 4 to 6 weeks for it to start acting upon the patient. So in the interim period, it is the steroids which is going to take care of the patient's inflammation. So when the dosage of steroid comes down, the effect of the immunosuppressive is at its maximum. And as ma'am rightly said, it's quite important because I see general ophthalmologists are kind of convenient. They find it safe to start off with steroids. But when it comes to immunosuppressives, they don't want to take care. And that's when they generally tend to refer patients to a uveitis specialist or in conjunction with a rheumatologist. So that's probably the second question. Why should we, I mean, when do we refer a patient to a uveitis specialist? So I think one of the reasons would be when you're scared to start an immunosuppressive and monitor the therapy of the patients. But otherwise, these patients generally tend to do well unless it's very aggressive right from the beginning. So what are your take on when do you want to see a patient referred to you to a uveitis specialist?
Yeah, if the general ophthalmologist is pretty sure about the diagnosis, like we see, yeah, if they're sure about the diagnosis, they can directly, like as you said, the first line therapy would be steroids only. It will be IVMP. If it's an exudative RD or disc, obviously you should start on IVMP. They can give the IVMP if they have a setup there. There should be a sister to give. IV line should be put. They are comfortable in giving that. If they are scared or the system is not helpful for them to give an IVMP, because the patient has to come there for 3 days, you should lie down and take the medicine. If that situation is not there, one, they can send it to the center where they can give the IVMP. Or the alternative is high dose oral steroids can be started. That anyway, that physician who is in the periphery, they can start on oral steroids. But before starting the oral steroid also, I would like to check the blood sugar of the patient.
Yes.
Basic complete hemogram should be noted. Before that, never start just by seeing an exudative RD or a serum, start on directly on Visalon. So do the baseline, it will take 2 days, no problem. Do that, then give the patient on a high dose oral steroids.
Right.
Suppose if it's
And
not possible, then only you refer.
So is there a role of MRI in the diagnosis?
As you said, patients might be having this disc changes. The patients, if they lands up with the CNS meningismus signs, yes, because this clinically, it is a clinical diagnosis. VKH, once you see the patient with uveitis and disc edema, obviously the first diagnosis will be putting like that only. So we don't do routinely MRI, but some cases when we see there is a close differential which is overlapping it, when the treatment is not going in the right way, can there be any other optic neuritis component there which is affecting? In that case, like we said, a neoplastic or a paraneoplastic masquerades, that
Exactly, ma'am. I think most often ophthalmologists will not be the one ordering for the MRI, but we do get patients referred by the neurologist who happen to take a CT or MRI, note the serious elevations in the retina, and then they refer the patient to the ophthalmologist. So I think an MRI would probably be an investigation done by the neurologist who then detects it and sends it over to the ophthalmologist to further take over, managing the case. So moving on to the next question. Can VKH happen without a prodromal period? And how many days does it take for steroids to take effect?
it can happen without a prodrome, but that means the patient was not smart enough to pick up a prodrome. Most of these patients, malaise and headache and milder fatigue, they will miss it up. So they will say, I never had fever. I was absolutely normal. I was in the office. Next day, I had blurring of vision. So the milder prodrome might have been there, but it might have been missed. Prodrome is just an immune response. So if the immune missing that, so that's why we didn't get the history. I think in that way, instead of there was no, we cannot say there was no prodrome by taking the history, because prodrome it's an history-wise symptoms only, and only headache we do not consider as a simple prodrome. There should be some associated for the neurological also, headache with tinnitus or some something like that. One patient actually had a epilepsy. She had seizures itself at presentation. So it can happen like a varied, or sometimes there will be nothing vision and you see bilateral disc edema with SRF. That's what in Indian population, the study I showed you in the slide, extraocular signs are less in Indian population. Most of them, they come with ocular, directly with the ocular findings of reduced.
And how many days does it take for steroids to take effect? I think this kind of goes to which form of steroids you're going to start treatment with. If it's IVMP, it's going to be very soon. You can actually see the difference in 3 to 4 days. If it's going to be oral steroids, it may take at least a week or 10 days. So, Divya ma'am, you would like to add on to it? Have you tried PSP for patients with the VKH? Have you ever given?
Yeah, I have given for patients, because some patients like you, they have this comorbidity where they cannot tolerate oral steroids. And sometimes with oral steroids, and I feel they will have, there is a very bad condition where the body is so aggressive to get the stimulation and there is antibody reaction. That case,
all right. So there is an image which is shared by Mr. Francis Raymond, and this was an image of an OCT of the disc. So they're asking whether does this happen usually after the third day of IVMP? Can you comment on this picture? We can probably come back to it later.
there is a
Or
picture.
you can open the chat. There is a picture of the disc. There are membranes on the cup, which is it probably a spillover from the macular edema? That's what his question is.
Is it there in the chat? I cannot.
Open the chat, madam. So I think he's talking about a patient. He shared the fundus picture, the FFA, and the disc OCT. After day 3 of methylprednisone, it's not a hot disc. I mean, the FFA is not very, it's not, there are hyperfluorescent patches, but I'm not able to see any late cooling. It's just one face of the image. And the OCT also, you really can't comment on, I think, these two isolated images. Divya ma'am, your take on that?
Yeah, here in the OCT, we are seeing some SRF here. Actually, fluid is accumulated. So yeah, the patient has already underwent IVMP 3 doses, isn't it?
Yes.
Yeah, but even after that, we still see some fluid accumulation. This OCT actually, this if it had been a grayscale, it would have been easy for. There is a thickening of the
macula also could actually help the rest of the
OCT macula would be a better
So
option.
if you could share further details on this case, and let's just probably go on to, yes ma'am?
Any history, he has written any history for this patient?
No history has been given. I'll just move on to the next question. When do you do a PI for VKH patients? Do you wait for the acute inflammation to subside or immediately at the time of presentation? I think PA is generally not advocated for VKH patients. It's only for the complications which develop for, following a secondary angle closure. It could, I think ma'am was talking about the varied presentations of VKH. You can, confuse it with an acute angle closure glaucoma. So over to you, ma'am, to answer this question.
Yes, in acute patient with choroidal thickening and ciliary body thickening, which is causing the angle closure, you are not supposed to do PI at all. You have to control the inflammation. You have to give IVMP, steroids, control the inflammation. Slowly, the thickening will reduce. This AC will become shallow. It will become deeper. So wait for the inflammation will settle down. So only when there is after control of inflammation still persists, then only you have to do a PA.
Exactly. There's one more question. I think you're talking about retinal saturation. How do you measure retinal saturation in uveitis patients?
See, retinal saturation, that's in the retinal oximetry, something where you have to measure the oxygen saturation. It's available in our system. It's not available. It's all research studies in which they have noted that the retinal oximetry, it's a oxygen in retinal blood vessels. So they have studied and they have noted maybe there is an alteration in uveitis patient that could have predisposed for neovascularization. That could be the pathophysiology behind that. But clinically, we cannot detect right now with the technology what we have. We can do OCTA after the neovascularization happens. We can note it down.
And the next question, any role of biologicals in the treatment of VKH? Yes, definitely.
Type of immunomodulator therapy only. That's what I showed you study in Chinese population in which they have tried steroid-free group and only that immunomodulator, this adalimumab group, and they have noted that the other immunomodulator adalimumab group was safer and tolerable. But in our setup, we actually go for the IVMP, oral steroids, and combining with immunomodulator. And that is what we do. In refractory cases, even with oral steroids, immunomodulator, they are not getting recovered, then we will send for rheumatologist for biologics.
Again, the next question is, how do you monitor immunosuppression in autoimmune diseases in a clinical setup?
Monitor immunosuppression.
When the patient has started on immunosuppressive therapy, what are, I think, the routine investigations which you do? You've already covered it in your talk, but if you could just summarize.
Modulated therapy, like suppose the patient is on mofetil or methotrexate or azathioprine, even steroids, you have to check the baseline cellular counts for these patients, like neutrophils, lymphocytes, all the baseline cell counts should be noted. WBC's level, because they can affect your bone marrow. So bone marrow suppression is in all your chemotherapy or the immunosuppressants, so that you have to check. Second, specific organ damage like hepatotoxicity or nephrotoxicity. And these are the common tests, CBC and LFT and RFT is a routine we do for these patients. As I told you, 6 to 8 weeks is the time frame, because in Indian scenario, it is very difficult for every fourth week you give blood sample. With that itself, the patient will become anemic, because these patients will take 2 years of immunosuppressant. So my protocol, so far I have followed, is doing well for these patients. 6 to 8 weeks, that's what the time frame I give to do.
Yes.
And blood sugars for patients who are on oral steroids, obviously blood sugar you have to monitor.
So, and rightly said, has, you don't start away the full dose of the immunosuppressive right from the beginning. If you're going to be starting with azathioprine, you can probably start a 50 milligram BD dose and then review the patients in 2 weeks or 3 weeks with the blood test again. If the patient is not developing any major side effects, sometimes it could be as serious. One patient didn't want to continue with azathioprine because she had very serious hair loss. She had patchy alopecia and she just didn't want to continue with azathioprine. So I think there are certain cases, not only blood related. It could not be just not agranulocytosis or, there could be issues like cosmetic issues when one patient strictly didn't want to go ahead with azathioprine because she had chunks of hair coming out every day. So then we had to shift it to another drug. So it would be ideal to review the patient in 2 weeks after you start an immunosuppressive. And once the patient is tolerating the drug very well, then increase it to the full dose, be it with any drug, azathioprine or methotrexate or MMF. If it's azathioprine, 50 milligram BD, and then you put on to the actual dose of 50 milligram TDS. With methotrexate, you can start off somewhere around 15 to 20 milligram per week, and then increase it to a maximum dose of 25. With MMF, again, you can start 500 milligram BD, and you can go to a max of 1.5 milligram BD. A maximum of 3 gram per day can be taken. So this is how you generally start off when you want to start off with an immunosuppressive in a clinical setup. First, when you start, probably after 2 weeks, you monitor the blood test. And after that, for every review, 6 to 8 weeks, as ma'am said, that would be the ideal way you review patients. So Ashvin has got a question for us. What are the typical OCT findings in classical VKH with regard to the neurosensory retina, RPE, and choroid, which will help us in, taking care of the differential diagnosis as well. The OCT.
I spoke on that.
Yeah.
Changes because basically VKH affects the RPE, choroid, outer retina, that region only. So you will be having the subretinal fluid accumulation, septate formations, and fibrinoid deposition, intraretinal membranes, and seesaw or the sawtooth in the outer plexiform layer, and the bacillary layer detachment, loculations. These are retinal level. And the RPE level, you will have undulations. This will be there in the RPE. Choroid, you will have thickened choroid, increased thickness will be present. So these are the features in OCT, and basically you will be seeing more of the subretinal RPE changes only in the OCT. And
right.
Another thing I want to add, in methotrexate, it's a weekly dosage. Remember, you have to mention in the prescription weekly and exactly right or Thursday in the prescription, because sometimes patient will mistake for, because most of the drugs will be daily. So you mention it is on Wednesday in this after food you have to take. Next we'll give folate and the prescription. Folic acid should be given for supplementing these patients that they can have associated anemia, other cells get. So folic acid also weekly or twice. You mention it in the day, like in the Thursday or Friday, so that they don't confuse when they.
I think the role of PST, there's also one other question. We've already discussed that. The next question is, what is the treatment for VKH in pregnant women?
In pregnant women, VKH in pregnancy, it is a little difficult only. And usually steroids in the first 3 months of pregnancy, we don't give. We will be putting the patient, if needed, only one of the injection where PST can be given after getting clearance from the gynecologist. And that is what we do. Even in breastfeeding patients, in the immediate postpartum, in oral, we will avoid oral steroids. We will be giving PST injections only. And immunomodulators, none of the immunomodulators we give. We will wait for delivery, then only will progress, because all these drugs are like, whether you start an immunomodulator, methotrexate, azothane, are not going to cause any effects on the child. So there is no written or there is no standard study protocols in which they have studied these immunomodulators in pregnant patients. That is why usually steroid would be the safer side, in which you give local therapy instead of giving systemic.
I agree. 3 months, the first 3 months is going to be quite crucial because that's when you're not allowed to put the steroids as well. But anytime after 3 months, the patient is going to develop an acute, steroids can be given safely. And out of the immunomodulators, which ma'am was talking, azathioprine is relatively safe. I've had to use in a couple of patients who are pregnant for other conditions. I've not used in VKH. Azathioprine I have continued in pregnancy, explaining the risks to the patient. But if need be, we have to continue them on immunomodulators. So I think it's been a wonderful talk and a great discussion following that. Let's just take one last question. Do you do genetic testing? Yeah.
No, we don't do genetic testing because VKH is a clinical diagnosis. And usually it is easily treatable also when you pick the patient in the early phase. If you are thinking of the offspring, like if you're genetic testing, basically for the sibling or the offspring, that is what you're
I
going
don't
to
think
gain for genetic.
there is a genetic association with the DRB1 allele being mentioned, but this is not one of the conditions which warrants a genetic testing, ma'am. If that answers your question, I think.
Yeah, that is what we don't routinely do it. And because it's a clinical condition, there is no need for actually genetic testing to be done for these patients. The diagnosis, like it's clinical, we get it, identify it and treat it. And that's it. So there is no role of genetic as such in this condition. Like you say, but yes, the diagnosis depends on that. Or ankylosing spondylitis, we have to do the HLA-B typing. Here, it is not related to that.
Right. Thank you, ma'am. Thank you for this great talk and the wonderful discussion. And I thank the clinical board for giving us the opportunity to moderate and have this great session getting back. So I think we are bang on time to finish it. Calling off. Have a great evening. Thank you so much.